NEET PG Mock Test Image based exam discussion of the today's test. Is the voice audible? So, subglottic stenosis according to the Cotton-Meyer's classification, grade 1 includes less than 50% of obstruction, relatively a non-standard question. But our anatomy teacher is a bit obsessive on some of the vague ENT questions. So, subglottic hemangiomas, all the hemangiomas do not sink. Some may require medical intervention is what you need to remember. Regarding the tracheal anatomy, you need to remember that trachea is not a bony structure. It is 50 to 20 C-shaped ring-like structures is what need to be remembered. Typically, the tracheal obstruction is associated with the Chios, the syndrome Chios, whenever it is congenital. Coming to tracheomalacia, tracheomalacia has nothing to associate with any bony rings, bony outgrowths of tracheal rings, but it is due to intrinsic tracheal abnormality where the maturity of the cartilage is not at the time of birth, that lead to the collapse of the cartilage leading to a stridor in a newborn baby, as all of you know very well. Now coming to the tracheal atresia, typically if you look at the atresia, it is one of the reasons is flaccidity of the supporting cartilage ring is the one which is a underlying responsible factor. Coming to the tracheal webs, so both acquired form and congenital form, there are two kinds of the tracheal webs. Now coming to the carina, it's a very simple question. Carina is on the lower end, not on the upper end. So I think easiest question in the world. Then main bronchus, right main bronchus, left main bronchus, you need to know a bit of anatomy. So if you look at the epiarterial branch, as the name itself says, it is superior to the right lung is what need to be remembered. Now coming to the left main bronchus, it is smaller in caliber but longer than the right main bronchus. That's the reason left lateral position is the position where you make the person to prevent the development of aspiration pneumonia, somebody who is in a comatose stage. Now coming to the bronchopulmonary segments, each of all these bronchopulmonary segments are separated functional units which are separated from the lung by a septum of connective tissue is what need to be basically remembered. Now what is this anomaly which is coming like an offshoot from the trachea? So it is basically called a tracheal bronchus, is basically an accessory bronchus that can arise directly from the suprachiasmal part of the trachea. Now what is this type of bronchus basically called as? It is called cardiac bronchus because it arising from the intermediate bronchus segment. Now what is this anomaly of the bronchus where the outpouching is coming out of the bronchus? It's called as a bronchial diverticulum, where it is a blind-ended outpouching which is coming from the bronchial tree. Now coming to the tracheal diverticulum, both the congenital and acquired forms occur. This is a repeat question. Now with regard to the drug and its mechanism of action based on a picture, this is one of the favorite ways by which NEET PG mock test image based questions are very frequently asked. So chloramphenicol is the drug which is being shown, and why do you think so? So what is the mechanism of chloramphenicol? Chloramphenicol interferes with the peptide bond formation and transfer of the peptide chain from the P site to A site is what you need to basically remember. So if you did this question wrong, you need to go back and study all 8 antibiotic classes, penicillins, macrolides, tetracyclines. What is the mechanism of their action? Is it 50 years, 30 years, how much years? You must be very sure when you go to the exam. For that, once more you need to go to the biochemistry and review the protein synthesis, RNA, DNA. So in biochemistry days we don't read DNA, RNA. That is the reason we don't read in pharmacology, drug antibiotic mechanism of action. That is the reason general medicine looks very horrible. So it's all interconnected. Karma and sin of the last life will be running behind our life, present life. So you have all these videos available on the uMedico video library. Go to biochemistry, go to RNA, DNA, protein synthesis. 20-30 minute video lectures are all available, right? So you can review them. Now what is this drug? That is typically when instilled, the light reflex was abolished and the corneal reflex was present. If you look at epinephrine and the atropine, they both lead to mydriasis. Why atropine lead to mydriasis? Because it is anticholinergic. Acetylcholine constricts the pupil, anticholinergic dilates the pupil. Then why epinephrine is mydriatic? Because epinephrine typically stimulates the dilator pupillae directly. So that's how it causes. But atropine also abolishes the light reflex, but the epinephrine doesn't have an effect on the light reflex. That is what you need to basically appreciate, that the light reflex is abolished, because for the light reflex to happen, how does it happen? The light falls on retina, it will go to Edinger-Westphal, the oculomotor nerve. Edinger-Westphal is a parasympathetic relay nucleus. So atropine is parasympatholytic drug. That's the reason it affects the Edinger-Westphal nucleus. That's the reason it also abolishes the light reflex. But epinephrine has no effect on Edinger-Westphal nucleus. Do you have idea about what is Edinger-Westphal? I am trying to go like a Shatabdi Express. You should understand that, yeah. So basically it is like this, that which phone it is? See, it is something like this. Typically you have the retina, on the retina light falls. So from there the optic nerve comes to the midbrain. Once it comes to the midbrain, from here it will go to pretectal nucleus. Tectum is in the midbrain. From pretectal it will go to both the sides Edinger-Westphal nucleus. From the Edinger-Westphal nucleus on the both sides, typically the ciliary nerves start. So it will go to ciliary ganglion, from there ciliary nerves, and ultimately it will go and supply the sphincter pupillae. So when you throw the light, it will go to pretectal nucleus to Edinger-Westphal on both the sides, and then ciliary ganglion to sphincter pupillae, and that lead to development of this sphincter pupillae to constrict. You can ask them to sit inside. Sphincter pupillae to constrict, and that is the reason for the pupillary constriction is what you need to basically remember. So if you happen to use atropine, which is a parasympatholytic drug, come. You can as well sit until your next class starts, no problem. Yeah. You can as well sit until your next class of ENT starts, no problem if you have energy. We have a quick mock test discussion. We'll finish anyway. You are in final year, right? Third year, that is ENT ophthalm going, right? So anyway, next year you are going to go into general medicine and all subjects. So before your ENT teacher continues, we will finish. So gotcha. So that is the reason if you give atropine, which is a parasympatholytic drug, Edinger-Westphal get affected and the sphincter pupillae doesn't work and the light reflex get abolished. If you happen to give the atropine is what you need to basically remember. So we have a 300 MCQ NEET PG exam, right? In that 150 questions are all image based. So we have a discussion on that. So before your teacher comes. Now, what are the drugs that act on the site A? What do you have site A? Dihydrofolate to tetrahydrofolate, right? So which one doesn't act? If you look at trimethoprim, pyrimethamine, proguanil, they all basically act when dihydrofolate become tetrahydrofolate. But how does para-aminosalicylate act? It inhibits the folate synthesis directly. That's what you need to appreciate. Now in this, a drug C is being instilled. Both the light reflex and also corneal reflex is present. What is that drug? Most likely, which has typically an ability to lead to meiosis, but doesn't affect the light reflex and corneal reflex. The pilocarpine. Pilocarpine is cholinomimetic or anticholinergic. Recently you passed out micropharma, no? Pilocarpine is mimetic. Huh? So that's the reason it leads to development of meiosis. Even morphine lead to development of meiosis. Okay. But when will light reflex or corneal reflex get affected? The light reflex will get affected whenever Edinger-Westphal is paralyzed. That's what you need to remember. That will happen if it is a parasympatholytic drug like atropine, not with a parasympathomimetic drug like pilocarpine. So that is what you need to appreciate. Entire success in medical school is how well you studied pathology, pharmacology. They are the only two subjects entire medical school. Everything is simple. And a good amount of basics in physiology. You read good pharmacology means you read good physiology also, right? So that's the reason if you have not read pharmacology properly but still passed exam, passing exam has nothing to do with how good you are with, right? Still you have a good time, fill up those gaps, autonomic nervous system and autonomic nervous system pharmacology. Now this graph shows the bioavailability when you have given the drug by two routes. So which is the true statement? In the first route of administration, zoom, the plasma concentration shot up. That is only possible if you give IV. Slowly it raised means it is oral. So that is what examiner is asking, that the curve A depicts the bioavailability by IV route and curve B by oral route is what you need to remember. Now with regard to these two drugs, drug A and drug B, you are seeing the response to different types of responses. So for every drug there are two things, efficacy, potency. What is the meaning of efficacy? What is the meaning of potency? Typically, when you give a same drug, two different drugs, for the same dosage, if there is a higher therapeutic response, that is called greater potency, right? So typically in this case also, do you like to call that drug A more efficacious or more potent? So drug A, height of the curve tells about efficacy and more height of the curve indicates more efficacy. So what is the meaning of efficacy? Typically when you give two drugs in same dose, right? Same dose, if drug A produces a higher amount of therapeutic response than the drug B, you call it as not potency, efficacy, right? Efficacy. But if there are two drugs that produce the same effect, but you require drug A in larger amount than the drug B, dosage wise, then you call it as if you need less amount of dosage of drug to produce same effect, that's called more potent. So potency is to achieve same level of effect. If you require lesser amount of drug, you call more potent. Then when you use two drugs with the same dose, if one produces higher effect than the other, then that is called more efficacious. It is like some students read a lot but awfully fail in exams. What are they called as? Less potent. Some people read only last few years questions and then pass exam. What are they called? More potent. And some students equally read, but one get more marks, but other get less marks. Who is more efficacious? More efficacious, right? So that's what you need to appreciate. Now what is this typical picture is showing? Whenever the drug is passing through 4 half-lives, it is affecting a it is reaching a steady state concentration. So steady state plasma concentration is reached after 4 to 5 half-lives is what you need to basically remember. Now what is this drug whose mechanism of action has been shown? 5-HT means 5-hydroxytryptamine, serotonin. So the serotonin reuptake typically is being prevented. So which drug has that kind of an action? Fluoxetine is called SSRI, that is selective serotonin reuptake inhibitor is what you need to basically remember. Now what is this anti-epileptic drug and which is acting on the voltage gated sodium channel? Whose mechanism of action is that? Typically which drug it is? Drug A, right? Not drug E. Drug A, yeah, it is acting on GABA. So that is the reason benzodiazepines, they facilitate the inhibitory action of the GABA, and that is how they act like an inhibitory, anti-epileptic drug. Now this drug A typically is acting on, what is the mechanism of action of this drug? So typically you have antiarrhythmic drugs classified into class 1, 2, 3, 4. 4 are calcium channel blockers, right, etc, etc. Within class 1 you have 1A, 1B, 1C. So 1A, they decrease the slope of the phase 0 of the cardiac action potential and they prolong the repolarization. So that is how the class 1A. So what are the drugs under class 1A? Quinidine, procainamide, etc, etc. So once more, the antiarrhythmic drugs, their classification and what is the effect of each of the antiarrhythmic drugs on the action potential duration, repolarization phase and the slope of the phase 1, phase 0. All these things you should master in pharmacology. That has got a great impact. So the drug B, how does it basically act? You have a drug B. Where is drug B? Yeah. So drug B is acting on typically the GAT. So the GABA transporter is called GAT. So it is the tiagabin among the anti-epileptics. Mechanism is basically by inhibiting the GAB transporter, that is GABA transporter is what need to be remembered. Then this drug E is acting on the voltage gated sodium channel. So that is the mechanism typically of the phenytoin prolongs the inactivated state of the sodium channel. Then this particular drug B, where is drug B? Yeah, this drug B, typically where do you see it as a mechanism of action? Typically ribavirin. What is the mechanism of ribavirin like drug? Ribavirin is used in respiratory, acute respiratory distress syndrome in children, right? Respiratory syncytial virus. So it acts by inhibiting the GTP, and by acting on the GTP, typically it will lead to the viral RNA synthesis getting affected, which is the mechanism of ribavirin. Then what is this anti-epileptic drug D? Basically what is its mechanism of action? It is acting on the potassium channel, right? So typically by opening KV channels, retigabin like anti-epileptic drugs basically function. Now what do you see in this ECG? In this ECG, you all have the access to uMedico? uMedico app, video library access is being given, right? So there you will find my Atma with so many videos. Do you have access to all the video library? Earlier ENT lectures? No? If you don't have, please claim, right? You're all eligible to, already we discussed all ENT which is being taught now to you. But only listening to video is boring job. So you need to have some live. So you have live, you have got video, and even these recorded lectures of ENT, are they coming into the app regularly? So you have got a way to revise, right? So your job is only to hear and write exam. No chance for reading the books. We don't want to give that chance to you, right? So you have a prolonged QT interval. What is the normal QT interval? 0.42 or 420 milliseconds. More than 600 milliseconds, you call it as prolonged QT interval. So there are a group of drugs which are known to prolong the QT interval. What are they? There is a list to remember once more. So becoming topper is once more batti marne ka kaam hai. There are a lot of things that you have list to remember. But most important is you should know case based, clinical vignette based, right? How to guess in the exam, right? Now quinine, moxifloxacin, terfenadine, all these drugs prolong the QT interval. Now which form of the vitamin B12? It acts as a coenzyme in this reaction. So vitamin B12 has many forms. So it is the deoxyadenosyl cobalamin is the form of the cobalamin in which it acts like a cofactor. Now which drug basically is the mechanism of action where it goes and inhibits the epoxide reductase? Warfarin is the drug, basically it affects the vitamin K metabolism and acts like a anticoagulant by inhibiting the vitamin K epoxide reductase is what need to be remembered. Now identify what is this drug A and what is its mechanism of action, which is a pentasaccharide sequence basically. Fundamentally, what is heparin? Heparin is a polysaccharide. So it inhibits factor 10A and factor 2 because of its elongated structure. Now do you know intrinsic pathway, extrinsic pathway and all this funda? You know or you don't know? You know? Very good. What are the three coagulation factors common to both intrinsic pathway and extrinsic pathway? 2, 5 are 10. What is the prothrombin also called? 2, factor 2 is the other name for, right? So the prothrombin 2 becoming thrombin, which is called activated prothrombin 2A, is all the necessity of the coagulation cascade. For this, it gets inspiration from two different sources. So for this conversion to happen, 5 and 10 basically work. So for this 5 and 10 to work and 2 becoming 2A, you either get inspiration from factor 7, which is called extrinsic pathway, and all other factors which are then called intrinsic pathway. Factor 9, right? Factor 8, etc., they all come under intrinsic pathway. Then there is one factor which is not part of this or the common pathway or extrinsic pathway or intrinsic pathway. Which factor it is? Factor 13. So after the clot forms with the platelets, after the fibrin mesh forms, this is being stabilized by factor 13. Hence what is this called as? Clot stabilizing factor is the name which is being given. Now if the factor 13 is deficient, patient will clinically bleed, right? He will clinically bleed, but his PT or APTT checks what? Intrinsic pathway. PT checks extrinsic pathway. They are normal, they are unaffected, but patient clinically bleeds. That is the important point you need to recognize, right? So you must know what are meant by the direct thrombin inhibitors and indirect thrombin inhibitors. That is how the anticoagulants are divided into. Once more, it's a long story. So go back to the uMedico app. In that you have got 625 high yield topics, right, for the undergraduate, and in that you go to pharmacology. In that you go to the anticoagulants topic, and my Atma will come out and teach you how to remember antiplatelets, anticoagulants. So always we should keep filling the gaps what we did not study. See, once more, if you are reading SPM, what is SPM? Sleep promoting medicine. So if you are studying SPM, once more you will read about chickenpox, polio, blah blah blah, which we did not read in microbiology but still passed exam, right? One more opportunity to read back. Otherwise medicine is very limited. There is only subject called pathology, pharmacology, bit of physiology, right? So if you did not read, at least now you read. Microbiology days also you don't read polio, you will pass. For vaccinations you don't read polio in SPM, you will still pass. In general medicine, pediatrics, anyway you don't read polio also, you will pass. But NEET PG exam ultimately holds your neck. Polio 1 type or polio 3 type, which is most common type of strain that leads to epidemics, which lead to endemics, which is the most virulent form. All this blah blah blah, you have to sort it out from that dense forest, not park. It's called park textbook, but it is. Are you still reading park textbook of SPM, or it is only for post-graduation? For those people who don't get good ranks and take SPM, so only they read, or you also read? Good. So what is the drug and what is the mechanism of action of this drug? It's a low molecular weight heparin which only inhibits factor 10A and not factor 2. What is the difference between unfractionated heparin and low molecular weight heparin? Unfractionated heparin inhibits both factor 2 and also factor 10A, but this only inhibits factor 10A but not the factor 2 because of its short structure. How do you monitor heparin's efficiency in the hospital? By checking the APTT. But do you need to check APTT even for low molecular weight heparin? You don't need to check the APTT for low molecular weight heparin. Now, what is this drug and what is its mechanism of action? So, it is basically fundaparinux, which has got only a pentasaccharide sequence is what you need to basically remember. Now, a 40-year-old with retrosternal burning pain. So, what is the diagnosis? It's typically a Barrett's esophagus. A 40-year-old endoscopic biopsy, Warthin starry stain means Helicobacter. So typically Helicobacter lead to development of gastritis. Now 40-year-old with dyspepsia with the stomach resected, and what is the gross appearance looks like? You are having multiple hypertrophic gastric folds which are suggestive of Mentrier's disease. Then 40-year-old hypertensive has got abdominal pain and small bowel was resected. What is your diagnosis? Actually that image was missing. Was the image was given in the exam? Given, good. So there is a wet gangrene of the small bowel shown in the image. So you have all these mock tests available on the mobile app also, right? You can always test, you can see how others are answering, you can chat with other people on the app. So that way uMedico app is a revolution in a community based preparation together. 40-year-old with abdominal pain, colonoscopy is being shown, so and he has got loose stools. What he has got is a pseudomembranous colitis, classically with a whitish membrane on the mucosa. Now a 40-year-old with hepatomegaly with ascites succumbed to it and autopsy was taken. So classically this is the appearance of a nutmeg pattern of liver, which is typically a feature which you see in the case of the congested venous occlusion is what you can see. Now a 40-year-old, once more it has a repeat question. Now a 25-year-old pregnant woman with eclampsia with a subcapsular hematoma leading to abdominal pain. Whenever abdominal pain is there in a eclamptic woman, one of the complications of eclampsia is development of a subcapsular hematoma is what you need to basically remember. Now 45-year-old, now your ENT classes, are they delivering the old question based, previous questions based or general topic? Topics, but it's always much better old questions to review. I think you may be given the question papers, old question paper. Hardly there will be not more than 30 topics to read in entire ENT to pass exam. Ophthalmology 25-30 topics, that's all, right? Once you are good with glaucoma, cataract, retinitis pigmentosa, visual field defects, blah blah blah, you are ready for what you call 20 to 25 topics is all that you need to master and read, okay? So you quickly read them, take every opportunity to see few cases, then your confidence will be much better. A 45-year-old has got a right hypochondriac pain, and what kind of stones you are seeing? Multifaceted stones. Typically multifaceted stones are all cholesterol gallstones. Whenever you have a condition where there is a lot of hemolysis, bilirubin is released, then you get pigment stones, the second type. A 45-year-old has acute renal failure, kidney biopsy typically showing what? Typically showing crescent shaped structure, crescentic glomerulonephritis is what you are able to basically see. So what is the meaning of crescent in crescentic glomerulonephritis? How does a crescent form basically? So all of you know very well, there is a Bowman's capsule. So the Bowman's capsule, इसके अंदर क्या होता है? Glomerulus. So the Bowman's capsule has got a visceral layer and it has got a parietal layer. The visceral layer typically has got podocytes. And what is the meaning of minimal change disease? Podocytes lose their anionic charges so that the protein can leak out. So the parietal layer, if it undergo proliferation, then all the proliferated parietal epithelial cells of the Bowman's capsule form a crescent shaped structure, and that kind of glomerulonephritis is called crescentic, not crescentric like eccentric. Crescentic. As an MBBS student, I used to say crescentric, trick, until after joining MD, once pathology professor said, please don't insult. A topper in NIMS exam cannot keep telling crescentric, trick. There is no trick about it. So you call crescentic. What is crescentic in a pathologist term? In a clinician's term is what? RPGN, rapidly progressive glomerulonephritis. Clinically it presents like a sudden elevation and renal failure, sudden elevation of urea creatinine. So clinically it presents like RPGN, clinicians call it, and when you do histopathology what you find is crescent formation and crescentic glomerulonephritis is what you need to remember. Glomerulonephritis is the most important topic in pathology, doctor. Most dirty topic if you don't properly understand it. So we have got a complete review. What is FSGS, etc. Membranous, membranoproliferative, what is MPG and type 1, type 2, all these things you have to have. Tips mein rehna for the tomorrow's exam. 45-year-old diabetic with acute flank pain and kidney was dissected, and what is the diagnosis? So typically it is pupillary necrosis. If you take analgesics excessively, analgesic nephropathy, sickle cell disease patients typically, then the third type, diabetic individuals, right? In all these people, typically the papillae of the renal structure that get necrosed, right? So that's called papillary necrosis. There are 3 to 4 causes for papillary necrosis. One is analgesic nephropathy, second is sickle cell disease, etc., etc. Now 45-year-old diabetic patient with flank pain, kidney was dissected. What is your diagnosis? Looking at the gross morphology of the kidney. So typically there is a scarring on the external surface of the kidney. That's the reason it's a case of chronic pyelonephritis. One more 45-year-old diabetic patient with flank pain, kidney was dissected and gross picture is shown. So what is the diagnosis? So it is a diffuse cortical necrosis that you are able to see. Diffuse cortical necrosis whenever there is any ischemic injury to the kidney, right? So there is a diffuse cortical necrosis. A newborn baby is born with a subumbilical lesion. So what is this clinical lesion basically? It is exotrophy of the urinary bladder. So next year when you come for the general medicine surgery gynocs final year classes, So we will review in surgery what is the difference between exomphalos and omphalocele, etc., etc. Now a 40-year-old excruciating pain in the scrotum and the testis was excised and it is completely dark and necrotic. So typically it happens in torsion testis. Torsion testis is a surgical emergency basically, right? Now a 40-year-old lethargy, weight gain, even a 6th class student also CBSE will answer this question, right? Cushing's. 40-year-old with hypertension, sweating and panic attack and adrenal was removed. So and panic attack and adrenal was removed. So this yellowish coloration is suggestive of more of a FEO actually. FEO should be the correct answer. Now a 40-year-old with purulent rash, itching purulent rash, actually this picture has no relationship. Psoriatic picture was shown, right? Now a 40-year-old with bullous lesion, direct immunofluorescence shows IgG deposits in a fishnet pattern, which is very classical of typically pemphigus vulgaris, right? Then 40-year-old complained of skin lesion on the elbow and abdominal pain, and there is a IgA deposition in the dermal papillae, which is classically the feature of dermatitis herpetiformis. IgA nephropathy and the dermatitis herpetiformis. I mean IgA deposition is a core feature. So with that we will call it a day.